pathology of the uterus. We have discussed the cervix. Now let's talk about the corpus or the body of the uterus. This basically comprises the endometrium and the myometrium. I hope you have reviewed the menstrual cycle, the estrogens and what the things that are involved in that. So the endometrium basically consists of the functionalis layer and the basalis layer. Why is this important? It's only the functional layer that is shed off during menstruation. The basal layer is the one responsible for the growth again of the endometrium. Okay, and this is also always under the influence of hormones. So basically, this is that. So we have here the entire thickness of the uterus. We have the periometrium layer, then the myometrium, the muscle layer, and this endometrium. This is the endometrial layer. We have the basal layer, and then the functionalis layer. And this functionalis layer, this area, is the one that is shed off during menstruation. And this functionalis layer undergoes cyclical changes with the effect of different hormones. So again, basal layer, or sometimes called stratum basalis and stratum functionalis. Notice that the endometrial glands stroma are all above the myometrium. Because if they are present here in the myometrium, that is a pathology, which we're going to discuss later on. So, again, the endometrium. This would be the proliferative stage. The proliferative stage, the glands will be tubular or slightly tortuous and lined by columnar cells, which are non-vacuolated. So these are the endometrial glands. The lining, called columnar. Notice that the columnar cells are uniform looking, arranged, sitting on the basement membrane. And here, these are their lumen, and this is the stroma. The typical stroma is, we call it cellular. To differentiate from other pathology, which is the polyp, where the stroma becomes fibrous. The polyp is fibrous, the endometrium normally would be cellular. So these are a schematic representation of the endometrium with its cycle. This is stratum basalis, and then it grows, okay, with the action of your estrogen, and then later on the progesterone, and then it's shed off. These are the actions of your hormones. And this is basically because of your estrogen and progesterone. Okay, what secretes estrogen? Just a little. Don't tell me it's ovary. Even high school student knows that. You are medical doctors. What secretes estrogen? What part of the ovary? Yes, the follicles. Very good. The Graafian follicles. And particularly, which Graafian cells with Graafian follicles? It's more the deca interna. Okay? Deca interna cells. The stromal cells can also contribute a little. Actually, estrogen is produced by a lot of cells, no? Like, would you believe your fat cells also produce estrogen? That's why obese person, they are prone to endometrial carcinoma. Why? Because of excessive estrogen. And we know that endometrial carcinoma is influenced by estrogen. That's why females are, we call that the fat female 40. Fat female 40, they are prone to endometrial carcinoma because of estrogen. Now, in the ovary, which is the main source of estrogen, okay, it's from the Graafian follicles. And again, what's stimulating the Graafian follicles to grow in the ovary? Okay, follicle. So it will be stimulated by the follicle stimulating hormone. FSH is secreted by this is important because as we go along, it has to be solid with your follicle stimulating hormone is secreted by anyone. Pituitary, very good. Anterior posterior. Anterior pituitary. Okay, very good. And this pituitary is stimulated by hypothalamus. By what hormone? Gonadotropin releasing hormone. Okay, so when puberty starts, the gonadotropin hormone will stimulate the pituitary to release FSH and LH, and this FSH and LH will stimulate the ovary to produce estrogen. And when ovulation comes, the LH surge will cause the ovary to release now a different hormone, which is progesterone. It is. So here, we have the primordial follicles of the ovary here, and then with the action of FSH, it develops. Your primordial follicles becomes your Graafian follicle and it matures. One ova is extruded out during ovulation. During ovulation, that ova is extruded out. And this follicle becomes your corpus luteum. And this corpus luteum, okay, the same follicle that releases estrogen before it releases estrogen, it releases estrogen. However, after ovulation, it becomes a corpus luteum which secretes progesterone. Is that clear? Okay. Let me go into the topic. So, if there's no ovulation, if there is no ovulation, will there be progesterone? What secretes progesterone? The corpus luteum. And what produces the corpus luteum? The ovulation. So if there's no ovulation, there's no progesterone. At least the right amount. We call that anovulatory cycle. Okay? Still with me? If there is no ovulation, do you think there's a chance of pregnancy? No, because there's no ova that is extruded out. So when there's no ovulation, no ova is extruded out, no formation of the corpus luteum, no progesterone. That's the anovulatory cycle, which we'll discuss more later on. But that's very important. That's why I want to emphasize it. Now, this corpus luteum will eventually atrophy to produce your corpus albicans or your athletic follicles. Now, if there's fertilization, this corpus luteum will become your corpus luteum of pregnancy. If there is fertilization. So this is how it is. There's another one. So, primordial follicle, and then gonadotropin releasing hormones stimulates the pituitary. The pituitary releases FSH, and now, so your follicle starts to grow. And as it's growing, it releases estrogen. It releases estrogen, and then ovulation happens. This usually happens at around 14th day of a 28-day cycle. 14th day of the 28-day cycle. And then you have your corpus luteum, which will now secrete progesterone instead of estrogen, becomes mature, and if there is no pregnancy, it becomes your corpus albicans or your athletic follicle. And then the cycle continues with the next menstrual cycle. This happens again: estrogen, ovulation, progesterone, and the cycle continues. Okay. Don't worry, girls. You have plenty of follicles. You will not run out of follicles during your lifetime. Okay. This is the same thing. Okay? Same thing. And this is important. the rise and fall of hormones. This is the ovulation. Estrogen is this. So notice that estrogen rises until it peaks here, and then it falls down. What rises? The portion is this. Which is your the LH first. The LH, we call this the LH surge. And the LH surge will convert that follicle into a corpus luteum, which will now secrete progesterone, which will slowly increase like that. Basically, what's the action of estrogen? What's the effect of estrogen on the endometrium? That would be the progesterone. The effect of estrogen is to make it grow, to make it thick. We call that the proliferative phase. There's proliferation of the endometrium, so it becomes thicker. But it's thick, but not yet prepared for implantation. And what will you prepare that for implantation would be your progesterone. So, in the early stages, the estrogen will make the glands go under hyperplasia. The growing growth, okay, so now there are many glands. But these glands are not secretory. They don't secrete anything. And we can see that because when you look at the columnar cells, they do not show any vacuoles. The presence of the vacuoles signify that the endometrium is now in the secretory phase. We actually use that when we do what we call endometrial dating. Okay? Like for example, the presence of vacuoles under the nucleus in the early stage, we call that day 16 of the 28-day cycle. When there is presence of predominantly all columnar cells, not all, but most of them, will show some nuclear population that's around day 70. And this is important. Endometrial dating is important in infertility studies. Okay, but that's the other topic. Okay. Once you become OB or gynae, we will learn more of that. But for now, let's concentrate on proliferative and secretory phase. And these are the hormones involved. So again, look, this is menstruation. Okay, the first day of the menstruation is day 1. So it will shed off the endometrium, and then with the follicular phase, estrogen rises, and your endometrium grows, becomes thicker. And then ovulation happens with the LH surge, at least at around 14th day, the ova is extruded, and now becomes your corpus luteum, which will change the endometrium to a secretory phase. And how do we know it's secretory? One, the glands are no longer tubal, but tortuous. The glands becomes tortuous, just like a saw. Okay? And more importantly, the lining cells become vacuolated. That's vacuoles. And then the presence of vacuoles will extrude it out, and the stroma, which is cellular, becomes plump. They become plump. Pre-visualization, we call that, in anticipation of a possible implantation. If there's an implantation, then the secretory phase proceeds to gestation of the endometrium. If no implantation happens, then the endometrium is shed off back day 1. Okay, so far so good. And this is your endometrium. Proliferative, notice the glands are oval and no vacuoles. Secretory, notice the vacuoles in the columnar cells. And notice the gland, it's now tortuous. Here it's just oval or tubular, becomes tortuous here. Okay. And here it's the late secretory, you can see secretions. These vacuoles will secrete to condense into the lumen. And the stroma, notice here, they are small, but here they start to become plump. Prediscolorization, plump. And here's the meso stage. It's bleeding. Then we call that stromal collapse. The stroma becomes dissolved and bleeding ensues. Now, this is an example of an atrophic endometrium. Notice that it's thin. Thin, and the glands are more or less scanty. Sometimes there can be cystic changes. And notice the lining epithelium is flattened. You see this in postmenopausal women. Postmenopausal, this is the endometrium. So far, so good. Any questions? So, what is the role of endometrial thickness? So, during menstruation, it is about 2 to 4 millimeters. Day 1 to 4. Early proliferative phase, about 5 to 7 millimeters. Then late proliferative, up to 11. The secretory phase, 7 to 16, 1.6 centimeter. That's the thickest. But in endometrial hyperplasia or endometrial carcinoma, it's going to be way thicker than this. Okay. So proliferative phase of the menstrual cycle is basically acted upon by the estrogen and you have slit glands. Secretory phase is basically acted upon by the progesterone producing tortuous glands plus secretions as evidenced by the baculization. And then menstrual phase, the hormones decline. Okay, and so there's menstrual shed, endometrial shedding. And this is the axis, hypothalamus, secreting gonadotrophic releasing hormone, which stimulates the pituitary, secretory LH, FSH, okay, and then the ovaries, which creates your estrogen and progesterone. Why do I show this? Estrogen is supposed to have a negative feedback. When you have high estrogen, it will tell the pituitary to stop secreting FSH. Okay. But sometimes we can have tumors of the pituitary, tumors of the anterior pituitary, which will continuously secrete FSH, and so the ovaries will continue to produce estrogen. Okay. Get that, because when you go to endometrial hyperplasia, that is one of the causes. So again, just showing endometrium, shedding, proliferation, secretory, and then shedding again with the hormones. Okay. And then this is the ovary, follicle, developing, grafted follicle, and then at the 14th day, ovulation, and then becomes your corpus luteum, and then it becomes your athletic follicles or corpus albicans. This is a picture of the ovary, the schematic representation. 14 is the magic number. That is where ovulation happens. We call this the proliferative or follicular phase, the secretory phase, or your luteal phase. Luteal because of corpus luteum. Now, causes of normal uterine bleeding by age group. I took this from Robbins, so you don't need to copy. Just put it in. Puberty, precocious puberty, adolescence, ovulatory cycle, ovulation disorders, application, complication of pregnancy, abortion, okay, complications. Okay, bleeding, uterine bleeding, classify them are anatomic bleeding or dysfunctional bleeding. Anatomic is there is something there that's causing the bleeding, like a polyp, okay, or like an infection. or like anything anatomic. While dysfunctional is hormonal. There's a problem with the hormones. That's why it's the function that is causing the bleeding. Pero yung menopausal dysfunctional literally bleeding also. Postmenopausal endometrial atrophy can cause bleeding too. Okay. Now let's talk about functional endometrial disorder. There is no structural abnormality. No polyp, okay? Nothing anatomical. In short, the problem is purely hormonal. And most of the time, it's because of an ovulatory cycle. So this is the most frequent cause of dysfunctional uterine bleeding. Anovulation is a condition where your ovary does not release an egg during a menstrual cycle. It results from hormonal imbalances. Most common at menarche and in the perimenopausal period. Why is it common in the menarche? Because the axis is not yet mature. So there is irregularity in the way the hormones are being released. But once the woman becomes more mature, then the hormones becomes more stable and this usually disappears. Okay? The same thing at perimenopausal. It's now subsiding, so the hormones becomes erratic and so sometimes it can also cause bleeding. These are the other causes. Endocrine disorders like thyroid diseases, ovarian lesions like granulosa cell tumor, generalized metabolic disturbance like obesity, malnutrition, and chronic diseases. This can all produce an ovulatory cycle. Okay, anovulatory cycle, failure of ovulation results in excessive endometrial stimulation by estrogen that is unopposed by progesterone. As we mentioned earlier, your progesterone is secreted by the corpus luteum, which results from ovulation. So if there's no ovulation, there's no corpus luteum. If there's no corpus luteum, there's no progesterone. And if there's no progesterone, there is unopposed estrogen. And what's the effect of estrogen? It stimulates the endometrium to grow and grow and grow. Okay. Grow, and then theoretically, normally, rather, grow, and then when progesterone sets in, stops growing, and then prepares this endometrium for implantation. But if there's no progesterone, no progesterone, grow, no progesterone. And then now we have a very big endometrium, which will cause, as you might expect, too much bleeding. Because more endometrium is being shed off. So instead of using only through 3, I don't know how many pads you use a day, it becomes more. Okay? Becomes excessively more. Sample up. You're using probably 2 pads a day, maybe now you're using 5 pads a day. Because the bleeding becomes excessive. So that's a clue. That's a clue when you make your history. How many pads do you use in your normal menstruation? Doc, I use only about 1 to 2. But now I'm using 5, sometimes 7 pads per day because there's too much, it's always soap. Other thing you ask, soap. Because sometimes they just have too much money, they want to change. Even it's not really soap. I learned that, by the way, I learned that from my pediatric professor. Okay? I never forget my professor of mine. I learned that from him. Pediatric, so it's not about bleeding. It's about urination. This is the lesson. You might as well tell you, I have plenty of time. He asked us during our case conference, what's the case? Diarrhea. Okay? Did you ask the mother how much the child urinated in a day? Okay. Of course, you will have to know the diaper. And then the mother said he changed the diaper 3 times a day. Did you ask the mother what's the color of the color of the diaper? Did you ask the mother, is the diaper totally soaked or just lightly soaked on the middle portion? So that told me, it stayed in my mind that when I do history taking, you don't stop at how many diaper. You ask what's the color, you ask how much is the diaper wet. No? Same thing here. So when you ask the woman about her menstruation, ask how many pads they use. Okay, when you change your pads, is it totally soaked or just the middle portion? Then you will have an idea how much bleeding there is. Okay? Endometrium is composed, in anovulatory cycle, the endometrium is composed of pseudostratified glands and contains scattered mitotic fibers. And if not corrected, it may lead to endometrial hyperplasia. Fortunately, if a woman has an anovulatory cycle, many times the next cycle will be ovulatory. It's not always anovulatory, but when there is persistent anovulatory cycle, then hyperplasia can set in. And later on, even endometrial carcinoma, because endometrial carcinoma is also heavily dependent on estrogen. So, upper part normal. Developing follicle, okay? Follicle, rapid follicle. So here estrogen, here progesterone. So estrogen, progesterone. However, in anovulatory cycle, follicle develops, okay, no ovulation, so follicle develops, and you have too much estrogen and no progesterone. Okay, again, this is more proliferative. Look at the glands, tubular, oval, with stratified columnar. This one is secretory. Look at the vacuoles. This one, notice now some glands are cystically dilated. This is what happens when you have anovulation, okay, because of the action of estrogen. Okay, this one, well, the glands are small, okay. Not so sure about this. Okay, this is again, notice the glands are of various sizes, shape. Normally they're supposed to be uniform looking, but look at this one. It's ruptured, but notice that it's cystically dilated gland. It's ruptured gland, but notice the cystic. Same thing here, cystic gland. This is one of the characteristic of anovulation. Also a characteristic of endometrial hyperplasia, because both of them are influenced by high estrogen. Both of them. Questions so far? You're so quiet. Let's continue. Inflammatory disorders. Basically, you can have acute or chronic inflammation of the endometrium. Acute inflammation, or we call that acute endometritis, usually happens, usually due to bacterial infection. And when does this happen? Usually after delivery or after miscarriage. Especially if this miscarriage is artificial or induced not by medical professional but some unscrupulous people like those like who wants to elicit an abortion in a bad way. I remember one case I had when I was a clerk. I had one patient, and when I did an examination, I saw a catheter. Catheter that we used to get urine. It's inserted into the uterus, into the uterine cavity. It's one form of abortion. It's really very bad. By the way, okay, let me tell you this. When you see such situation when you are already a doctor, it is incumbent upon you to report this to the authorities. That is our legal responsibility to curb illicit abortion. Okay, these are illegal things. So we have to report to the police. Don't worry, hindi kayo report sa police. It's the hospital. You report it to the hospital, and the hospital will contact the police. And the police will do the investigation. For any medical legal cases, gunshot wound, stab wound, okay, you have to report it. Because these are medical legal cases. And as physicians, we have to report it. It's our duty to prevent crimes from happening. Okay, let's go back. So bacterial after delivery miscarriage, or even after a normal miscarriage, but some products of conception retains. And this retained products of conception is a fertile ground for bacterial growth. That's why we have to remove those retained products of conception by DNC. We have to get them. We have to clean the endometrial surface of these retained placental fragments. They're usually placental fragments. The usual organism, a lot of them. Strep, staph, many other organisms. This endometritis usually seen in the stomach. Chronic endometritis can also happen. This one is associated with chronic pelvic inflammatory disease, or any of chronic ophoritis, chronic meningitis, anything chronic that can involve the endometrium. Can also be caused by retained gestational tissue. It can also be caused by an intrauterine contraceptive device, or your IUD, okay, which used to be a popular means. I don't know if it's popular now, but it used to be for birth control. IUD. It's inserted into the uterine cavity and it can cause chronic endometritis. TB can also happen, but it's not so common because the endometrium is continuously being shed off every month. But it can happen. And I've seen one. I've seen TB endometritis in my practice. Now the diagnosis, this one is important. The rest of the identification of plasma cells. Okay. So just leukocyte, not so much. It's the plasma cell, the presence of plasma cells in this stroma, which will tell us there's a case of chronic endometritis. And in the TB endometritis, the presence of your Langerhans giant cell. Okay? Let's say, 5 minutes break. Getting over.